My name's Danielle Lavallee. I'm in the Department of Surgery. I'm not a surgeon. I'm a pharmacist by clinical training. My focus is really on patient-reported outcomes. So while you've spent the morning really focused, and you'll spend the afternoon focused on skills and knowledge that you need to be the amazing surgeons that you are, I'm going to take some time before you go to lunch and talk about the why. And that's why you guys do your work. That's to improve function and to reduce pain. So for the people that come into you, especially here in the Northwest, that say, hey, I really want to get back on the golf course or back hiking and biking, or if we ever get snow again, back out skiing, how do we measure that in a way that can help inform the work that we're doing and also the conversations that we're having with patients? So I'm a little bit jealous of Dr. Johnson's slide because he had a very similar one, only it was Homer Simpson. You focus a lot on the clinical aspects of work. What's really cool here in the state of Washington is when SpineScope, as Neil was just describing, started back in 2011, it was before I started, the surgeon community said, you know what, in addition to the clinical measures that we capture, we also want to look at pain and we want to look at function because that information really complements what we're doing clinically and helps us better understand how our patients are doing long term. So the state of Washington is really cool in the sense that you guys are benchmarking across practices. It becomes challenging though when you start to look at how do we compare hospitals or practices that are in Seattle to to Tacoma, for example. And then how do we look across this at the statewide level? That non-integrated healthcare system and the ability to benchmark when EMRs are different and they don't talk to each other is no small feat. And so it was with this aspect, so with SpineScope, a lot of the information is coming directly from the medical record. Well, how do you do this when you want to start looking at patient-reported outcomes? That isn't something that's traditionally captured as part of the clinical workflow, and certainly not easy to assemble when you're looking across different EMR systems. So based on what our early experience was implementing the PRO side, of the patient-reported outcome side of Scope in our community, we developed this certain hub, and this was really informed by a number of the surgeons here in this room, a platform that would help facilitate the capture of PROs, reduce the burden to staff in terms of scoring the different instruments, and then finding a way that we could bring that information to a central level to help support the clinical reporting that's happening as part of Scope. So the PRO metrics that were introduced again back in 2011 were general measures of pain, and this is something that's traditionally captured in healthcare, the 10-point NRS on a scale of 0 to 10, how are you feeling today or what's your pain today? And then the condition-specific measures. So we have the Oswestry Disability Index and Net Disability Index for lumbar and cervical spine, respectively. There was also a request to add a question about how satisfied are you with your spine surgery so far? And the intent behind this was there are hospital level measures using HCAHPS data that look at general satisfaction. If we're looking at pain and function, why not ask people, hey, how happy are you with your spine surgery? So we added that as a measure to look at to see if that would be informative to including to the general SpineScope measures. So the workflow, and this is where it gets tricky. Because people like to respond to surveys in different ways, we wanted to be able to respect that. So when a patient walks into an office, is how we start a lot of our conversations. They complete a baseline survey. We started in 2011 doing paper and pen. As many people can imagine, when you have a 10 points questionnaire that you have to score, that becomes burdensome to staff and takes away from patient care. So we instrumented iPads into clinics to help facilitate that capture. As part of completing those surveys, patients tell us if they're willing to be contacted in the future and how they want to be contacted, by phone, by mail, by email. Patient undergoes surgery by the number of skilled surgeons that are in this room and others. And then after surgery, we start about 60 days, we conduct outreach to then again ask them how they're doing with regards to the ODI or NDI, depending on their surgery and their pain and their function and their satisfaction. That information is then aggregated and sent back both at the physician level and then has the ability to look at the community level as well through Scope analytics. So one aspect that we hear from patients all the time, and if anybody in this room has ever been a patient, you fill out a lot of paperwork when you go into the clinic, and that information oftentimes goes into a dark hole. That you fill out all this information, but what does it all mean? And so what we wanted to do as part of this is to feed that information back to patients. So we work, because we're in the university system, we are able to tap into other departments. So there's groups called user-centered design and informatics that are non-healthcare generated. So we had some students work with us us to really develop out what the user interface would look like. So as patients go through, we have a user interface that allows them to understand or to complete the surveys online. But then it takes it back and it feeds back the information. So you've just completed a bevy of 12 questions. What does that information mean? And it provides back, here's where your pain score is, here's where your ODI score is, and here's what that means. So they can either use that for their own information or then discuss it with their physician. We also did the same process with surgeons, and we sat and talked with them about, okay, here's the data we're capturing. Tell us what information you want to see back given the metrics that we have available. So surgeons who are working with us have the ability to log in and look at their patients. They understand how many patients are responding, so what's the response rate? How do I compare? You can see the blue and the green colors. The blue looks at the individual surgeon. The green compares it to the broader population who's completing the survey at the community level. And we're starting to look at trend lines in terms of what do your patients look like in terms of changes in function and changes of pain over time. One of the biggest successes has been improving the data quality. So when we started this initiative in 2011 on a paper base, we had a really hard time getting the scores captured and reported. It wasn't that it wasn't necessarily being done. There were a lot of physicians and staff that were putting a lot of time into capturing this information. It was just more making sure that information made it from point A to point B to ultimately the scope metrics. By capturing this electronically, we have the ability to, as you see with the red line, increase the percent of complete data. So the scores for pain as well as the scores for function. And then with respect to follow-up, our follow-up rates right now using multimodal approaches are around 70%. Normal quality improvement data at the hospital level runs around 20 and 30%. So having higher numbers of completed surveys makes you feel a little bit better about what you're looking at. So increasingly, and I've got 5 minutes left, so I'm just going to go through a couple of different ways that we're looking at this information, highlighted by the fact that the community that we're building, the surgeons that we talk with on a monthly basis during our monthly research spine meetings, are really looking at this data to say, how do we interpret this and make it meaningful for quality improvement for clinical decision making? I think I might, oh, there's my mic again. So this is looking across different hospital sites at pain improvement at 90 days and looking at the variation and starting to understand how do we incorporate this as a functional measure. As I mentioned before, I'm not a spine surgeon, and some of the really great conversations we have with the spine surgeons is figuring out how do we interpret this. So meaningfully important difference for pain is a change in 2, so going from a 10 to an 8 or an 8 to a 6. Conversations with our clinicians is saying, you know what, it's really probably 3, so why don't we change how we're looking at that pain and relook at the data? It also matters which metric you profile on. So as I said at the beginning, we're looking at satisfaction as well as pain and function. So what this exercise was really completed for was to say, okay, if we just look at people who are reporting satisfaction with their spine surgery, what does it look like? And as you can tell, everybody does pretty well. Well, what if we start to look at satisfied, if they're satisfied and also have an improvement in pain or improvement in function, reduction in pain? The story looks a little bit different. And then what if we just look by pain or by function? And this isn't meant to say we are using the exact right measures, but it's meant to start the conversation of how is this information, how should this be used as we start to benchmark within our practices, across our practices. And why this is so critical is because payers and policymakers are going to start to expect to see this data and are also going to start benchmarking against it. So how do we as a community have a voice in that conversation? I have colleagues who are working in total joint replacement, and this is already taking traction for knee and hip replacement. And it is expected that spine surgery isn't too far behind. The National Quality Forum that endorses measures that CMS then uses is starting to look in spine fusion at how does the ODI then become incorporated into some of the quality metrics that we're using. So the advantage of having this community of surgeons together is that we can start to think thoughtfully about how this information is captured and have a voice in how that comes to fruition. Again, looking at satisfaction, pain, and function. So I showed you the slide about it depends on what you're measuring. This is a really interesting slide in the sense that if you look at the upper quadrant here, that's showing people who are satisfied. So the green indicates satisfied, red indicates not satisfied. If you're looking at the y-axis, you're looking at an improvement in pain. If you're looking along the x-axis, you're looking at change in function. So what we're seeing is for people who fall in this 96% category where they're 96% satisfied, those are people who are having improvements in pain or reduction in pain, improvement in function. So that's what you would expect. When we look at the groups that show maybe not an improvement in pain, or improvement in pain or improvement in function. There seems to be a little more ambiguity when it comes to how they're reporting satisfaction. But what's really interesting is this lower quadrant here. So these are the people that are reporting that they're not satisfied. That they're satisfied. 58% of people are saying they're satisfied, but they're showing no change in pain or worsening in pain, and they're showing no change in function and worsening in function. So it's really interesting, implications for how we use this information, how we interpret it, especially when we're talking to patients. I'm going to talk lastly on the spine calculator, because now we're starting to look at these different measures. How do we then incorporate this into the conversations that we're having with our patients? As Neil alluded to, we have these growing amounts of data across all of our patients. How do we start to look at that and use it to forecast what people's outcomes would be on measures that are important to them? So I'm going to walk through a couple of different slides that show the calculator at a little bit more granular level than Neil showed. So it allows people to include their age, their sex, their insurance type, smoking status, their ethnicity. And then it starts to show the information. What you can't see, and I apologize for the tiny font, is the patient can indicate how would you like to see your function improvement outcomes with a function score, and looking at the change in terms of the number or the point change, the percentage change, looking at function or looking at pain. And then it shows people what they can expect for outcomes 1 to 3 months after their surgery or a year after their surgery. So it provides a visual tool to start the discussion with patients about what their expectations might be. For the past 2 days, I've been in Washington, D.C., working alongside some folks from orthopedic surgery, neurosurgeons, people from the American Medical Association, folks that are looking at the quality measures to really talk about how should patient-reported outcomes be integrated in and reported on for the respective both quality improvement and clinical decision-making. There's a lot of energy around making sure that if we're going to use this information, that we're capturing in a way that we have high-quality data and that we're interpreting in a way that really does advance the healthcare field. So in addition to being part of this, the local and regional community talking about these issues, what we hope to do is also support those conversations at a more regional and national level, so that the voices of the people who are doing the great work that's happening here is being heard also at the national level. So what I'm going to wrap up on is that, one, there's a number of tools, and that's increasing the number of tools that are available to capture and report on PROs. I've just presented one platform that we've developed based on the community here. Our goal is to enhance quality improvement and decision making, and to do that effectively, I believe that it really has to be in partnership with the community to make sure that we're hearing what challenges occur with the workflow, but then also understanding how best to report it back to inform practice. So again, we're creating the community locally, but with the goal of also connecting to a more national community to really talk and move this area forward.
Hey, thanks for visiting the Seattle Science Foundation YouTube channel. To find videos just like this one, click here. To subscribe to our channel, click right here. Or check out our website here, or see what we do by clicking right here. Thanks again for watching.